ليا شرف ان اقدم الزميل جمال السعدي هيتكلم على treatment of hypertension and coronary kidney disease. الدكتور جمال السعدي طبعا غني عن التعريف، هو واحد من البريليانت فيجرز في القصر العيني وفي السبيشاليتي بتاعت النفرولوجي. اتفضل.
بسم الله الرحمن الرحيم. Thank you very much, Professor Silman, for this very kind introduction, and it's a great honor to be sharing the Egyptian Hypertension Society annual meeting. ومؤسسة أستاذنا ومعلمنا الأستاذ الدكتور محسن إبراهيم. Actually, this topic is multidisciplinary and very important to be considered. حضراتكم تعرفوا الباترفلاي افكت للcomorbidities which is well known to all of us, leading to the cardio-kidney metabolic syndrome, and out of which the hypercholesterolemia and obesity are one of the important factors. The diabetes mellitus itself is a very important comorbidity, and on top of them is hypertension. All these may lead to organ damages, including chronic kidney disease, as well as to cardiovascular disease. If we consider the impact of these comorbidities on the atherosclerotic cardiovascular disease because of the important effect on the life expectancy or mortality. If we consider these risk factors and we consider the hazard ratio of any of them, and let us put the cutoff of 2, which is double the high risk value. Those who are having significant risk which is exceeding the 2, we find that hypertension is leading, followed up by the dyslipidemia, followed up by the CKD, which these topics are the title of our talk today. And they are exceeding, for example, the risk of diabetes, which is around 1.7 or 1.8 hazard ratio, and obesity, which is around 1.6 or 1.7. To consider the management of hypertension with risk factors or without risk factors, blood pressure between 130 and 40 systolic and 80 to 90 diastolic would be satisfactory for the general population, but in the presence of risk factors including organ damages with CKD up to grade 3, or in the presence with diabetes mellitus, it might be not suitable, and we need to target a lower blood pressure below 130. This is more also with the higher grades of or severer stages of CKD or cardiovascular disease. This is also important if we have additional albuminuria. You need to target a lower blood pressure below 130. To sprint beyond that might be not suitable in all cases. And it's mentioned that going below 120 might be risky and might be even harmful in some situations, particularly even in the presence of CKD and proteinuria. This is not the case with a bit older age, where we can consider 140/80 a suitable blood pressure for this age category. If we go to the pathogenesis of the hypertension with CKD, there is a reduction in the nephron mass and the nephron number. There is an adaptive hyperfiltration in the residual nephrons. This would lead to stimulation of the renin-angiotensin and aldosterone system. And this is a key player. That is why we need to target this renin-angiotensin system to block the pathogenetic mechanism, and as well to reduce the glomerular hyperpermeability, leading to proteinuria and ending as well into nephrosclerosis and focal segmental glomerulosclerosis and interstitial fibrosis with progress of the CKD. You can notice that there are key players in the pathogenesis of hypertension with CKD, including a very significant endothelial dysfunction and oxidative stress, which needs to be targeted, the renin-angiotensin system, as well as the aldosterone excess. The aldosterone and renin-angiotensin system should be targeted, and it is very important to consider ACEs or ARBs as a beneficial line of treatment, wherein in end-stage kidney disease, sometimes we prefer to start by ARBs, sometimes in the cardiologists would prefer the ACEs, particularly in myocardial infarction. The guidelines all recommend blood pressure below 130 and 80, and they all recommend the use of ACEs or ARBs, and it is a high recommendation. The consideration in management of hypertension with CKD is to target the efferent arteriolar pressure with targeting efferent arteriolar vasodilatation to reduce the intraglomerular pressure. This might be mediated by the angiotensin II stimulants, as well as the T-type calcium channel blockers. طبعا حضراتكم تعرفوا ال L وال T-type calcium channel blockers. ال L-type is only present on the afferent, but the T-type calcium channel blockers, the lercandipine, is present as well on the efferent arteriole and acts similarly to the action of the ACE, as well as the aldosterone, which also acts on the efferent arteriole, and all these by efferent arteriole vasodilatation would reduce the intraglomerular pressure, preserving the life expectancy of the Malpighian corpuscle, as well as the reduction of the proteinuria. The main lines of treatment in such a situation of CKD and hypertension definitely includes the RAS inhibitors, and we should consider the SGLT2 inhibitors as a main line of treatment for CKD and as well as hypertension, because SGLT2 inhibitors, as I will show in coming slides, have important hypotensive effect, and they are inducing polyuria. So having these combinations in hand, we should consider the non-steroidal mineralocorticoid antagonists, and if the hypertension is severe, we can replace the non-steroidal in addition definitely of the calcium channel blockers. But if we have severe hypertension, we need to replace the non-steroidal by the steroidal MRA. They are having a more hypotensive effect. The aldosterone mechanisms with reduction of the glomerular filtration rate and the glomeruli number results in aldosterone excess. It has a deleterious hemodynamic effect with sodium retention, and through the macula densa, they reduces the closo production. And the closo is very important in the pathogenesis of atherosclerosis and in the mortality as well, and needs to be well targeted. The aldosterone excess, as I mentioned, would lead to glomerular sclerosis, and it has an important effect on the endothelial dysfunction, leading to progression of CKD. All these also results in accelerated cardiovascular aging and increase in mortality. So we need to target all the pathogenic mechanisms leading to this reduction in the closo and risk of premature death. And you can notice that the closo lower line starts to decline from the early phases of CKD in comparison to other biomarkers. In the management of hypertension with chronic kidney disease, if still not controlled, we can add a beta blocker, or we can add later on an alpha blocker. It doesn't differ much if we have proteinuria or have no proteinuria, except in selection of some of the drugs. But generally, we'll have the ACE or ARBs, the calcium channel blocker. If we have proteinuria, it's better to select the T-type calcium channel blockers. The lercandipine would be more beneficial, and then we should consider adding a thiazide or a thiazide-like diuretic. We should also target the mineralocorticoid antagonists, and in addition, we should not forget the important endothelial dysfunction and the increase in the arterial stiffness in our management. Considering the diuretics, if we are going to choose a thiazide or a thiazide-like, we need to select those who are having longer duration of action. Similarly, if we are going to choose a loop diuretic, we need to have those with a longer duration of action in the 24 hours. So in the combination, we have an important triad to be considered, which are the angiotensin receptor blockers, the calcium channel blockers, and the diuretics. The further combinations which are beneficial for the chronic kidney disease and as well for the cardiovascular disease is that we should consider ACEs and ARBs which as an initial line of treatment, and SGLT2 inhibitors are in favor of both the kidney, the heart, and as well as blood pressure control, and they are also beneficial زي الدكتور كريم ما كان بيقول in prevention of hyperkalemia, which is an important risk factor in the combination of ACEs and ARBs and mineralocorticoid antagonists. The third important agent is the calcium channel blockers, and the finerenone now is one of the important pillars of treatment of such situations. I think the issue of hyperkalemia was well covered, and we should never lose the benefit of the pillars of treatment of kidney and heart disorders to avoid using the ACEs or ARBs or the MRAs. We should consider a very important dietary management, adding the SGLT2 inhibitors and the sodium bicarbonate if we have any acidosis will prevent against occurrence of hyperkalemia, and we should not refrain from starting these beneficial agents. وكريم طبعا خايف من المساءلات ومش عارف ايه، بس let us see the benefit of the patient, and before starting them we should consider dietary control, adding SGLT2 inhibitors, adding sodium bicarbonate, and if you have an additional diuretic it will be beneficial, and you might consider at what time you might introduce the potassium binders. We should not refrain from introducing potassium binders in patients who are receiving a lot of medications which are already very expensive. And this is now in the guidelines of the European Society of Hypertension, and they suggest using potassium binder to maintain normal or near normal serum potassium below 5.5 and to allow maximal doses of these important agents, because they have an important effect not only on the comorbidity and organ functions, but they are having a very relevant factor or important effect on the life expectancy. If we have resistant hypertension, we should consider sodium retention and the important use of diuretics, and this is the value as well of the SGLT2 inhibitors. Recently, the renal denervation was considered one of the factors which might be relevant in control of hypertension, but it needs expertise for this line of treatment and specialized centers. The uncontrolled blood pressure might indicate that we are using more than 4 drugs to control the blood pressure. We should exclude secondary hypertension. Sometimes we are forced to use more stronger vasodilators. The novel investigational agents, which I'll come in the coming 2 slides, are also important because they target as well other risk factors, and the renal denervation is kept in to only specialized centers. We might target as well direct renin inhibitors to block the formation of angiotensin 1. We can target the endothelin receptor antagonists either in the endothelium or in the muscle wall to avoid the systemic vasoconstriction. We can consider the central aminopeptidase antagonists, reducing the formation of angiotensin 3. Of the direct renin inhibitors, the screen is now getting a wide phase of clinical trials. Also the atrasentan and the sparsentan, which is a dual endothelin and angiotensin receptor antagonist, is of importance. The dual endothelin blockers, as the aprasentan, is considered in the clinical trials. Also, the aminopeptidase, which is firibastat, is running some clinical trials. Also, we have the aldosterone synthase inhibitors, baxdrostat, which is also considered in the clinical trials. We should target all these risk factors to avoid the butterfly effect, which might be simply controlled, but if left uncontrolled, it would cause a tornado of CKD and cardiovascular disease. And thank you very much for your attention.
Thank you, Professor Dr. Gamal, for this elegant presentation. My question لحضرتك blood pressure targets in patient with CKD and renal transplantation. Is it differ? Because there is some data about we adopt more lenient blood pressure targets than patients without transplantation.
هو حضرتك التوبيك ده كان بتاع المؤتمر السنة اللي فاتت، فكان توبيك مهم برضه، وهو actually it is almost the same. We should target below 130/80. Sprinting beyond this to lower blood pressures is not beneficial for the perfusion of the organ itself. We should not target below 120 as much as we can, except if you can have special indications with the heart failure and so on, and you are targeting lower blood pressure. You might face a patient who you can't raise the blood pressure beyond 110, for example. And there are حضرتك طبعا بتشوفوا الحاجات دي اكتر مننا، ان في patients مثلا السيستوليك بتاعه 90 to 100 and functioning very well. So these pressures might be normal to some individuals but should not be targeted. Yeah, below 130 120 is satisfactory.
Thank you very much, Professor Dr. Gamal, and it is a pleasure to introduce my dear